the last talk on this session, that is common mistakes in treatment by Dr. Bindu S. Ajith.
Good morning, everyone, and thank you, Malika, for this opportunity. So we all know we are famous for handwriting and the common mistakes we do while prescribing drops. There's a case scenario where a 76-year-old male was well controlled with medication, but on a recent visit found to be the IOP spike was found. On inquiry, he insisted that he is applying drops and his compliance was good. But then when he was asked to bring the medicine, this was it. We had prescribed one medicine and he was using some other medicine. Though with the handwriting, we have overcome that. With the advent of this ECHS and the needy medicines and all that, the prescription we give is not always the same medicines they have been. So we have to always be careful of this fact and tell them to bring the medicine and have a look at it before adding medicines to them. So that this is the common medicines which we always come across. The mistakes that they have been using is different from what we have been prescribing. And some of the combinations which we should be avoiding are the drugs which act in the same mechanism, like the pilocarpine and prostaglandin. One acts by decreasing the venous outflow, the other acts by increasing the venous outflow. So when you combine both, the effect of both are decreased. And adding medicines from the same group of medicines, like the latanoprost, travoprost, and bimetoprost, does not have an additive effect, but it has more the drug toxicity effect. So you have to be careful when you're adding these drops. And there's another patient who was given a prescription of drops, and then when checking the pressures, we could found that his pressures are not controlled, and it was because of the complication he had. He was feeling drowsy and he stopped the medication by him. So it's always the most common factor is the compliance factor, which we have to look into. Before starting adding medicines, we have a habit of keeping on adding medicines without looking into the compliance factor. So don't treat the IOP alone. See the patient as a whole before giving medicines. So we have seen that the compliance is the most important factor before we start medicines. Most patients miss some drops, and few miss all the drops. So the side effects which you have to look for is the hyperemia, the dermatitis, and the most common drug which we use and we think has no complications is the prostaglandin, which comes with the complication of prostaglandin associated periorbitopathy. So the trials, the most common adverse effect is also seen. The hyperemia is the most common cause of discontinuing medication. And when we did a study, we saw that 96% of the patient had this ocular surface disease by the third visit. So it is not uncommon for glaucoma patients to have this OSD, and it is very discomforting, and the patients stopped using the drops. And this is what I was talking to you about. And some of the drugs which we have to be careful is brimonidine in older age group, where it causes sedation, dry mouth. And timolol in young patients, it's not the bronchial asthma and cardiac contraindication. It causes psychosis and decreased libido in young males. So it's always, we have a tendency of just recording intraocular pressure when the patient comes. I think the fact of facing has to be given important. And it's not ideal to check 12 hours or 24 hours pressures, but then what is practical is we can call the patients at different time of their OPD and see for the facing. So it's the long-term control and stability of the intraocular pressure and not the single reading which you have to take into consideration when you're treating the patient. And it is not only the intraocular pressure, like you have to see the lifestyle changes. There are other contributing factors for the progression of the disease, like the sleep apnea, the yoga practice and the exercise practice that they are into, the head down yoga practice, or the weightlifting practice nowadays. So many of them are into gym. All that has to be asked about if the disease is progressing in spite of the medications. And then you also have to see into the systemic diseases also. So this is a case where a 22-year-old female just found to be IOP 25, And we all have a tendency of just seeing a single reading of pressure high, we jump into treating that intraocular pressure. Like in glaucoma, the under-treatment, the over-treatment is also as common as under-treatment. So just look into the other risk factors before starting medications to them. The importance of CCT was already mentioned in the previous talk. Now, this is another scenario where a 40-year-old female was referred as a blurring of vision with high IOP. She was diagnosed on primary open glaucoma and was on 3 medications. So, when these findings are jarring at us, it's easier to pick up, but you have to look up the subtle changes too. The dilated episcleral venous pressure and imaging, she had a CCF. Again, a 67-year-old male with complaints of primary angle closure. She was referred, pain, and developed severe pain after the PI. And he was prescribed Diamox, and this Diamox was caused the effusion and increased IOP. So the drug which is used to treat IOP can also cause problem unless you look for it. Another case scenario was a 36-year-old female with sudden onset of pain and blurred vision. And we all thought it was an acute angle closure glaucoma. And the drug history is very important because it's becoming more and more common nowadays. So this is the OCT picture showing the effusion. So there are lot many drugs, not only topiramide, there are lot many drugs which you should be aware of that can cause an angle closure glaucoma in them. Another scenario, a 36-year-old female with acute headache, pain, gonias closed. Always it is not angle closure glaucoma. When you have a bilateral angle closure glaucoma, go do a B scan and look for RCS thickening or any exudative RDs. You can have VKH and posterior scleritis presenting as acute angle closure glaucoma. This is a female presenting with increased IOP. She is high myopic. On dilatation, you see a spherophakia. So these are also conditions can present to you as glaucoma. Another female presented with reduced vision. IOP was 32 and 48. Gonioscopy closed, underwent YAG PI. IOP is still raised with advanced disc and field changes. On an examination, you can look at the fundus, shows a dilated vessels. One of the reason can be an anophthalmos, ruled out the anophthalmos by doing the axial length and ACD depth and lens thickness. Is it due to increased episcleral venous pressure? You can have surprises. This was a case of craniofacial fibrous dysplasia, or a case report was there as a rare cause of acute angle closure glaucoma. So all these subtle changes, you should pick it up, and it's not always angle closure glaucoma alone. There's another female who is on treatment for travoprost, now complains of pain, redness, and watering. And this is the picture. She's got a corneal edema with pigmented KPs. This is a viral keratitis. So now we know that prostaglandins can aggravate viral keratitis, and also in uveitic patients, we tend to avoid prostaglandins. So she was started on steroids, and I changed the travatan to brimonidine, and this is how follow-up pictures are. Now we have to be aware of this condition too, the bilateral acute transillumination, where there is a lot of release of pigments, and it can be preceded by an upper respiratory infection and oral intake of moxifloxacin. This also presents like a pigment dispersion syndrome, and so these are the conditions which you should be aware of when you have a high dispersion of pigments and the high intraocular pressures in the patients. So these are some of the common mistakes we do. It's common to do a mistake, but when we repeat it, it's not pardonable. So you learn from your mistake and move forward. Thank you.
Thank you, Dr. Bindu. You made it very simple and interesting by presenting all of them in the form of a case scenario. Very, very nicely presented. Do we have any questions? We don't have to rush because nobody is there waiting for another presentation. Since there are no questions, we are concluding our session. Thank you, all the audience. Thank you so much for the wonderful presentation. All the presenters. Thank you. Thank you once again.